In the previous lecture, we discussed the patterns of liver injury. Now, in this lecture, we will look at the pathology of some liver diseases and we see how these patterns express themselves. So we will be covering hepatitis, metabolic liver diseases, cirrhosis, primary biliary cholangitis, and hepatocellular carcinoma. So let's now discuss hepatitis. Hepatitis is the inflammation of the liver. It can be caused by an infectious process, most commonly viral hepatitis, that can be acute or chronic. It can be caused by an autoimmune process, such as autoimmune hepatitis, and metabolic liver diseases, such as Wilson disease. The most common cause of acute viral hepatitis is hepatitis B. Now, morphologically, we will see mild changes, that is, some mononuclear cells infiltrating the portal tract. Maybe we can see some balloning degeneration, necrosis, or cholestasis. Although these changes are mild, however, they will cause disruption of the architecture, known as lobular disarray. Alcohol is known to cause acute hepatitis sometimes, and here we will see certain specific morphological features such as the presence of neutrophils. So we can see here neutrophils surrounding necrotic hepatocytes. We can also identify the Mallory bodies, the eosinophilic Mallory bodies here, and we will see also fibrosis starting to surround these areas. In chronic hepatitis, morphological changes will be much more pronounced than in acute. Remember, most of the biopsies from the liver for hepatitis are mainly for chronic hepatitis. Etiologies that cause chronic hepatitis can be viral, autoimmune, metabolic, alcohol, or drugs, but all can progress to cirrhosis. In chronic hepatitis, morphological changes are more pronounced as compared to acute. The hallmark of chronic hepatitis is the dense mononuclear infiltrate in the portal tract. This infiltrate sometimes may spill to the adjacent hepatocytes and form a change called interface hepatitis. Also, we can see fibrosis. Fibrosis can be within the portal tract, called portal fibrosis, or it can bridge the portal tract to the central vein. Sometimes we might have necrosis of the hepatocytes along the portal tract and the central vein. Other changes such as steatosis, apoptosis, or even ground glass cell formation specific to hepatitis B usually are noted in chronic hepatitis. Here is the area between a portal tract and the hepatocytes, and you can see the mononuclear cells, the inflammatory cells, spilling to the adjacent hepatocytes, causing necrosis and death of these hepatocytes by, for example, apoptosis. This is what we mean by interface hepatitis. These changes that you can see here, like this one, this one, this one, and so on, are the ground glass changes of hepatocytes associated with hepatitis B infection. Sometimes the infiltrate is heavy and consists mainly of lymphocytes forming a follicle-like in the portal tract. This is more common in hepatitis C infection. In chronic hepatitis, a liver biopsy is performed not only to diagnose the condition, but also to grade the inflammation that can range from 0 with little inflammation up to grade 4. But more importantly is to stage the degree of fibrosis. This fibrosis can be limited to the portal tract or extend periportally or form bridging and finally can form cirrhosis. This is known as stage 4 where the liver will be diagnosed as cirrhotic liver. What we need to stage this fibrosis is a stain called trichromazone. This trichrome will give the fibers a blue color and will help us evaluate the degree of fibrosis. Chronic hepatitis can be caused by etiologies other than infection, as we discussed before, such as autoimmune hepatitis. Here we will have necrosis and inflammation, but what's important is that when we see plasma cells, like here, associated with the inflammatory infiltrate, then we have to exclude an autoimmune condition by doing further studies. A metabolic disease that will lead to chronic hepatitis is Wilson disease. This is an autosomal recessive disorder caused by the loss of function of the ATP7B gene. It will impair copper excretion into bile and cause failure to incorporate copper into ceruloplasmin. We can stain for this copper, and you can see the brown deposits here. This is copper, and it is associated with these green pigments that represent cholestasis. Another metabolic condition that may predispose to cirrhosis and affect the liver is hemochromatosis, which is caused by excessive absorption of iron, and this iron will be deposited in the liver and may lead to cirrhosis if left untreated. We can see the deposit has a blue color because it is stained with the Persian blue stain. The liver will undergo cirrhosis after chronic injury because of two things: the attempt to regenerate and forming regenerative nodules, and and undergoing fibrosis. So when fibrosis and regeneration happen together, we will end up with cirrhosis. Two cells are responsible for fibrosis: the hepatocyte stellate cells that transform into myofibroblasts. They are present in the space of these, and they will start producing the extracellular matrix as well as collagen fibers. Similarly, we have the fibroblasts, which are present in the Purkinje tract, and these will also deposit, when activated, will also deposit collagen and extracellular matrix. Morphologically, cirrhosis is a diffuse process. It will involve the whole liver tissue. As we can see here, the nodular architecture is involving the whole tissue, and the regenerative nodules additionally will be surrounded by a fibrous band. Now, under the microscope, we can identify these regenerative nodules, specifically when we use the Masson trichrome stain, which will stain blue the fibrous scores, and we can easily see these regenerative nodules. The nodule size can be small, that is less than 3 millimeter in diameter, and known as micronodular, or it can be large, more than 3 millimeter, called macronodular. Sometimes we have both micro and macronodular in the same tissue. Now, micronodular is more common with steatohepatitis, while macronodular is more seen with chronic viral hepatitis and metabolic diseases. One of the liver diseases that can lead to cirrhosis is primary biliary cholangitis, an autoimmune disease caused mostly by antimitochondrial antibodies. It affects the intrahepatic duct and its main morphological feature is inflammation that will destroy the small and medium-sized intrahepatic bile ducts. The patterns of injury in PBC will include inflammation. As you can see here, we have the inflammatory infiltrate in this portal tract, but additionally, these inflammatory cells will be attacking the bile duct and causing its destruction. Sometimes we can see with this inflammation granuloma formation. For primary biliary cholangitis to progress to cirrhosis, it has to go through stages of inflammation or duct lesions. These can start by simply portal inflammation or florid duct lesions, then can progress to periportal inflammation or bile duct ductular reaction, then can proceed to bile duct loss or bridging fibrosis, and finally to cirrhosis. So this image demonstrates the different stages. We can see here the periportal inflammation, we can see here the destruction of the bile ducts, and bridging fibrosis and cirrhosis in the last image. The cirrhosis pattern mainly seen in primary biliary cholangitis is micronodular cirrhosis. So now we will discuss the most common primary liver tumor, hepatocellular carcinoma. Now remember that the most common tumor of the liver is metastasis. Metastasis usually present as multifocal. However, with hepatocellular carcinoma, the most common presentation is unifocal. In hepatocellular carcinoma, the morphology will show distorted architecture. So we cannot now identify the single cell lining of the trabeculae. Instead, you can see that these are large trabeculae with many layers of hepatocytes. Moreover, we can notice the large atypical pleomorphic cells present all through this section. Sometimes, to identify a hepatocellular carcinoma, we will need to identify markers produced by these cells, and immunohistochemistry can be of great help here. Also remember that these cells can undergo mutation of the p53 gene. Now, hepatocellular carcinoma is known to be associated with cirrhosis. However, there is one variant called fibrolamellar variant that occurs in non-cirrhotic liver, usually young patients less than 40 years. This type of hepatocellular carcinoma usually will show morphologically these lamella of fibrosis in between the tumor cells, intratumoral fibrosis, and the hepatocytes will acquire a large eosinophilic cytoplasm, as you can see here, the large pink cytoplasm all through.